So our next speaker is Dr. Bullock, Kim Bullock over here. And Kim comes to us from Stanford University, where she has a few different roles. She's in this Department of Psychiatry and Behavioral Sciences, and she directs the Neurobehavioral Clinic and the Virtual Reality Immersive Technology Laboratory, really one of the few university-based centers that has research programs dedicated to understanding the role of virtual reality. And she studied it in a variety of different somatic conditions, I know in chronic pain and others, and she'll be sharing with us today her lessons learned and her experience as a neuropsychiatrist and what role VR plays in her field. Thank you for being with us today, Kim.
Thanks. Well, hello. Yeah, I'm getting really excited, and this is such an amazing conference. And I'm hearing a lot about the potential, and I've only been doing this about 5 years, so I feel a bit like an imposter, but I talk to a lot of people, and they're feeling kind of the same way, because there's a lot of people that have been, studying this for many years, and I think what I want to bring home in this lecture is, it's really exciting to have all this potential technology, but it's also really frustrating how to get that technology and develop that technology to the patient and to the bedside. And I'm hoping that these type of conferences will really inspire all of us to work together to develop all this potential and get it to the patient. Because I think last lecture yesterday from UCSF, Dr. Watchell talked about some of the challenges, and it was really validating for me. This is not personal. It's not just I'm having trouble getting from A to B. We're all having trouble because we're in an evolution with this technology, and so I'm hoping that this will conferences like this and talks will continue to inspire us to solve these problems, because we do have to imagine like radically outside of the box. So basically, I'm a neuropsychiatrist. A lot of people don't know what that is. I didn't know what that was when I was in medical school. It is a subspecialty of neurology, actually. Although, if you're a psychiatrist, you can actually get certified in this. So if there's any medical students around here, or neurologists or psychiatrists, you can do a fellowship, and you can take this horrible exam, and if you pass it, you can be a certified neuropsychiatrist. If you're a psychiatrist, you usually call yourself a neuropsychiatrist. If you're a neurologist, you'll call yourself a behavioral neurologist. So what that means for me in my practice as a psychiatrist is that I work a lot with neurology, and I see a lot of patients with comorbid neurological illnesses. But it actually, in reality, isn't very different than just a psychiatry practice. So my main focus is psychiatry and mental health. And so when I was in medical school, I was really torn between neurology and psychiatry. I chose psychiatry because of the complexity of it, and dealing with emotions and consciousness and behavior. But I was really disillusioned and got really burnt out by my 4th year, because we didn't have any biological markers. It felt like witchcraft. We'd sprinkle a little of medication here and a little of this here, and there were a lot of assumptions about medications from petri dishes, and then we were extrapolating this to be the mechanism of medications. And it was a very kind of dehumanizing experience in the 90s when I was training. And then luckily in my last year, I found a supervisor who was a psychiatrist who happened to be one of the founders of cognitive behavior therapy, David Burns. He wrote the Feeling Good Handbook. He was developed with Albert Ellis and Aaron Beck, the field of cognitive behavior therapy. And I started to use that in practice and started to do work on myself, and a lot of my mood and anxiety issues went into remission, and my patients as well, and I realized how transformative this was. And so I decided, yeah, I guess I'll stay with psychiatry. and I'm going to be a kind of a renegade, and I'm going to hang out with the psychologist. So I got myself a job at Stanford, but I'm in the psychosocial wing where we don't do much medication. And so for the past 15 years, I've really concentrated on more of a non-pharmacological practice, as well as being a neuropsychiatrist. So I was kind of a weirdo in that way. And then I also got trained in something called dialectical behavior therapy, which incorporates mindfulness and Eastern and Western philosophy into CBT. But a lot of it's classical and operant conditioning. And most of what I've done for the last 15 years, I see about 25 to 30 patients a week. And what I do in the office is basically exposure therapy with cue desensitization, a lot of the things you've heard about today. I've been doing with paper and pencil and just droning on between the patient and me. Distraction, teaching people distress tolerance, interpersonal skills. A lot of psychotherapy is actually skills training. So training people how to communicate, how to relax, things like that. And I didn't know until Skip Rizzo came to our neuropsychiatry meeting about 5 years ago on a horrible rainy week in Seattle, that there was this thing called virtual reality being done that would make my life so much more fun. We could bring toys in. I could actually put that on a patient, and they could be taught how to do mindfulness, that actually it would personalize and be more precise and enhance the treatment. So I got really excited about that. I also was a bit wanting to do something that had more to do with sensory motor. I felt like that was a missing piece with some of the patients. So anyway, what Skip brought to the conference was this huge evidence base, and I felt gypped because I didn't learn it anywhere in medical school. None of my psychotherapy training talked about this. I think Rothbaum, I'd heard one kind of random story about PTSD and Barbara Rothbaum's study, but that was about it. But there was a robust evidence base. So I really got it from Skip's lecture on PTSD and what he was doing, that, wow, there's this head tracking that will replace one's visual reality, and it can actually modulate cognition and emotion, much of what we were trying to do in the office. And then the other thing that I felt really mad about was that, wow, there's all this evidence, very robust evidence that's been going on for 20 years with anxiety disorders. We've got, and this might be old, this slide. This was about 6 months ago. I updated it, but if there's any errors, please let me know. But it looks like, we've got controlled trials, which, as an evidence-based physician, that's what you're looking for. That's, you kind of defend your practice based on that. But for social anxiety, there were 4 controlled trials. Panic disorder, 5 controlled trials. Fear of flying, 2 controlled trials. Specific phobias, there were controlled trials. Addiction, there's a lot of evidence accumulating. There's one right now for smoking cessation, but it looks like there's more coming down the pipe. Pain, there's one for acute pain, PTSD. Eating disorders, there were 4. I work with the eating disorders unit, a very prestigious, great group of researchers. They knew nothing about all this evidence for VR. Schizophrenia and autism is developing, and not so much for depression. I think there's some fear-based mood trials, but that's developing. All these things are developing. So I was kind of really excited about this and thought about implementing it in my practice. And one of my research interests were the more psychosomatic illnesses, one in particular, conversion disorder, because these folks, we're now using the term functional neurological symptom disorder. They're sort of an orphan diagnosis. It's at epidemic levels. About 30% of any patients that go to a neurology office in a tertiary care area will have this diagnosis. So it's a very, very common diagnosis, but people are unaware of it, and treaters, there's a training gap and a training deficit. So psychologists don't like to deal with this because it has to do with movements and somatic symptoms, and they feel they're not trained to work with that. Most of the clinicians I work with. And then the psychiatrists don't get much training in how to deal with this. So I ended up, my practice at Stanford ended up being a lot of conversion disorder folks, and the most evidence-based intervention for that is cognitive behavior therapy. So my research was really about delivering cognitive and dialectical behavior therapy and group therapy, and I thought that was going to be my life. That was going to be my research and my focus. But then I started to get notice that not everybody got better, and some people, 40 to 60%, were not getting better, that we needed to do better. And so I started to think about motor and sensory interventions that were lacking one component of the body and the whole person. We didn't have any sensory and motor interventions. And around that time, physical therapy started to come on the scene as an intervention that helped people with psychosomatic symptoms. So I thought, wow, we couldn't find any physical therapists in our area that knew how to deliver it. And if you took these patients and just referred them to physical therapy, they didn't do well with traditional physical therapy. They needed a very specific kind of classical conditioning and reinforcing and ignoring of behaviors you didn't want and rewarding of the behaviors you did want. So, so we had a gap in, and so I was looking for some things that could increase our ability to deliver that, and I heard that immersive virtual reality was being used for physical therapy. So I headed on over to Jeremy Bailenson lab that was across campus, and he's a very welcoming guy, will give tours to anybody, and I did the whole plank experience that it's funny to hear so many of the people up here talked about that it being a transformative moment for them when you really get it, you know, how precise and how personalized the cue and how much emotion can be evoked in an immersive experience. So I had one of those transformative moments and thought, how could we bring this, how could we create a motor sensory intervention? Because I knew, and from talking to Jeremy in his lab, and they were focused on some pain, that when you add movement as well as visual, movement and sensation and pain are directly linked in the brain. It's like the software feedback loop. So when your brain sees movement, it knows that it turns down pain. So when you think about it, when you're in pain, you don't move. And immobility and disuse starts to happen. So your reptilian brain goes, wow, we're not moving. We better turn up the pain because something serious is going on. But once you start, and the pain docs I talk to, once you start moving, the reptilian brain is like, oh, things must be okay because I actually can move that part of the body. So we don't need to be in as much pain, and it dials down the pain. And so there's an intimate connection between these things in the brain. So when you bring movement into the perceptual illusion, you have leverage into changing not only emotion and cognition, but sensation. So that was like fascinating to me. So I was trying to figure out how to do this. I started to review the literature and found, as Skip had talked about earlier, you know, there was use of this embodied VR in stroke and rehab, for motor skills training for surgeons, which we just heard about, Parkinson's disease, and some cerebral palsy evidence starting to accumulate, especially in children. But the novel, and then also some novel uses. with biofeedback, physical therapy, body image disorders. Mariva Giuseppe's done a lot of work in this area, which I'll talk about a little bit more, which also was quite inspiring to me. And then teletherapy, and then something called mirror visual feedback, which I'm going to talk a little bit about. So this, and then I think some other people also reiterated this. It looked like the mechanisms for, the proposed mechanisms of embodied virtual reality in these interventions were increased motivation, these multisensory conflicts modulating body representations, and this allosteric lock theory. So let me explain that, because that's what I'm really interested in, is how our sense of body and our sense of control is formed. There's a representation of that, and it gets formed from what we understand now. The theory is that we have an objectified self. We think like a third-party view who imagines what we look like, what our demographics are. Do I look fat or skinny to somebody outside? Am I a man or a woman? You have all these ideas of what the outside world. So it's sort of, if you were doing VR, it would be, you're looking from the third perspective. You're looking at your avatar. So one part of your brain is always looking at your avatar. And then there's another part of the egocentric view that's experiencing your avatar. And you have interoceptive sensations that tell you, like, oh, okay, I look kind of a certain size and a certain color. And this body representation, that your allosteric and your egocentric come together, and you form an idea of who and what your body is and yourself. But that there are some disorders or some problems that occur with one's sense of self, that when this top-down, what others think, and your objectified self overrides your interoceptive sensations. One could think about in anorexia, where maybe you've got these overly thin ideals, and your own body, you're not picking up the signals. You're just seeing yourself as fat no matter how thin you are. But that idea was very interesting to me in trying to help people with conversion disorder that have problems with both voluntary movements, having agency over their own body, and certain sensations. So the first use of this immersive virtual reality was really mirror visual feedback by Ramachandran down at UCSD. He was actually a professor of mine when I was an undergraduate, and he documented amputation of phantom limbs using this technology. And then Jeremy Bailenson actually created with Andrea Juan Stevenson, one of his graduate students in his lab, limb swapping, so mirror therapy in an avatar format. And I found this was so fascinating, and they were using it with pediatric kids with chronic pain, with complex regional pain syndromes, and they were having very good results. And so I wanted to use it, I wanted to experiment with this with my folks, because I started to read the literature, and I couldn't believe in my neuropsychiatric training and psychiatry and medical training, I had never heard this, that motor recovery, there's a very robust evidence base of the mirror visual feedback helping post-stroke hemiparesis, post-hand surgery. I talked to some neurologists who say, the only thing that's been innovative in the last 10 years that helps with stroke is mirror visual feedback. Yet no one is using it. Why? I don't get it. And I think there's a knowledge gap. There's a lack of information out there. And there's also the challenge of getting those resources. Once we identify that, getting those resources available. Unilateral pain syndromes, phantom limb, complex regional pain syndrome, inflammatory rheumatic pain, and then some exploratory uses in other neurological illnesses and overuse syndromes. So functional conversion disorder is sort of the intersection between psychiatry and neurology, and I couldn't find any reports of anybody using mirror therapy for functional neurological disorder or conversion disorder. And I guess for the interest of time, I may not go too much into this slide, but so I really wanted to try it because I think some of the problems, there's some hardware problems and some software problems in functional neurological disorder that embodied VR could help. So I was really interested in doing that. And that was right at the same time that the HTC Vive was coming out, and immersive and commercially available immersive experiences. And so we were able to take Jeremy's software and put it in my office. So I didn't have to drag patients over to try it over in his lab. We actually had a Vive that was delivering mirror therapy. And the mirror therapy neuroimaging evidence shows some really interesting things. One, that it increases attention and cognitive control, which helps prime for learning and motor and sensory reprogramming. And then it activates just a little bit the mirror neuron network, but it also increases this motor cortex, the ipsilateral motor cortex. And this is where my patients have a bit of trouble. They don't have voluntary control over that motor cortex. And I'm hoping from our use of it that they will, a neuroplasticity will find is happening. But anyway, what I'm saying is that mirror therapy actually causes plasticity in the brain to occur. So a perceptual illusion can change your brain permanently. Like, that's pretty amazing to me. And so we decided to explore it with FND for a number of reasons that I talked about. And then the other reason I didn't talk about is that many of the people with functional neurological disorder also have high rates of trauma, PTSD, social anxiety, and simple phobias, panic attacks, all those things that were listed as evidence-based interventions for VR. So there was even more reason to try it out. So we went ahead and did a feasibility and safety trial. We were able to get a grant, an internal seed grant, and then showed safety and developed a manual. And then now we're halfway through a randomized control trial, and we're delivering 8 weeks of mirror therapy, and we are mirroring wherever they're having a deficit or a problem. So if wherever in their body they're having a motor or sensory issue. So we are halfway through, and I'm trying to remain agnostic, so I didn't analyze the data. And we've got a few, we only had one episode of cyber sickness or an adverse event. I wouldn't even call it cyber sickness, which was pretty surprising to me because most of these people have central sensitization issues. They're very sensitive to everything. So if anyone was going to respond and have negative events, it would be this group of people. But we've had about 15 people really go through, and only one has had a negative event to the actually placebo. Looking just at the descriptive, one of the primary outcomes, it does look at the 4th session like the treatment group is improving. But again, I'm not going to make anything out of that because I want to remain agnostic. This may not work at all in these folks, and I'm totally open to that. But what's even more important than my little study here with FND is that I was a B or C lister in my department, okay? I started using VR, and I'm at the A list now. They made me director of this virtual reality clinic and program. Because and one of the wonderful things about that is it destigmatizes mental illness, and that is transformative. So now we are proud of this therapy we're delivering. it just, pairing technology and mental and behavioral health is quite profound. And so the other part of my job that I really love now is I'm in charge of just disseminating this in everything we do. So the first thing we did, I started researching a lot of platforms because I have other patients besides F&D, and how do we augment our CBT with this? And I found SciAS is the most easy to use, kind of idiot proof at this point, although we're open to finding other platforms and trying different things. And we also have been implementing it in research, in education, and in the clinical treatment. And so it's been really fun to watch. We've got an eating disorders, we got a NEDA grant from the National Eating Disorders Association to use it to augment traditional CBT to see if it will enhance that. We've got our group, Inspire group, and schizophrenia starting to use it. We have researchers using it for assessment. We have an apothecary. Now, Leanne Williams has designed a bunch of virtual reality interventions that elicit certain emotions and has standardized virtual reality environments that can elicit an emotion. And then I'm trying to also get it into the teaching and use it as a format for teaching, especially psychotherapy and using linguistic analysis. So many things have blossomed from this. It's been fun. And I hope that inspires other people too to keep doing that. And and the other thing that I actually learned how to use Twitter, which I had no idea. I'm not that tech savvy, so we do have a Twitter account and we have a consortium. Because one thing I realized once I got this appointment was that everything is about, we can't do this alone. I used to think academics, we need to stay away from industry because we don't want to have any conflicts of interest and we want to stay scientifically rigorous. But you know what? That's an old paradigm. We cannot, the technology is moving so fast, we cannot innovate without each other. We have to do this together. We have to have a network of conversations. And so we began this consortium, and we have, once a month we meet, and we have developers and people doing demos come in for half the meeting and demonstrate. And it's very effective use for everyone's time to have the demo at a time where everyone comes and all the clinicians are there and all the researchers. So if anyone would like to join our consortium, we're more than happy, and would be very helpful to us. And I think just increasing those networks of conversations is what's going to help us be creative, because one person alone can't be creative enough for this. We need the whole network involved. So. And I look forward, to any questions later, but thank you so much.